Good morning. So, without wasting any time, I invite the first speaker, Dr. Manojkumar B. Gaddikeri, on the dais. His paper is Sarcopenia a hype, or does it really affect the outcome of spine surgeries? Dr. Gaddikeri.
Good morning, everyone.
I have 8 minutes plus 2 questioning.
Good morning, everyone. I'm Dr. Manojkumar Gaddikeri. Before we dive into the topic, let us begin with a case scenario where two patients in their mid-60s present to us with this X-ray. They undergo a similar procedure, and we see that one patient is happy and gets discharged early, while the other patient ends up with wincing in pain, delayed mobilization, prolonged hospital stay, and ends up getting discharged late. I'm pretty sure most of us must have experienced such instances in our day-to-day practice, and after seeing this, we start to wonder why this happens. The answer could be sarcopenia. So we came up with a study to find out, is sarcopenia a hype, or does it really affect the outcome of spine surgeries? It was as late as 1980s when we first came to know of sarcopenia, when the term was coined by Sir Erwin Rosenberg. It basically means loss of skeletal muscle mass leading to impaired muscle function. Sarcopenia has n number of causative factors, with most common and important ones being old age, lack of physical activity, impaired nutrition, and hormonal causes. With a prevalence of more than 50% seen in above 60 years of age, it's a cause of great concern, as sarcopenia is a known and an important risk factor for repeated falls, fractures, disability, prolonged hospitalization, and bad post-op outcomes. An initiative by the name European Working Group on Sarcopenia in older people. They first met in 2010 and they defined sarcopenia based on muscle mass. It was as late as 2018 when they realized that muscle strength has more important role than muscle mass, and they redefined sarcopenia as muscle disease, and it was included in the ICD-10 for the first time. The group gave a criteria where if only low muscle strength was present, then it was called as a probable sarcopenia. Along with that, if there was low muscle quality or quantity, then that would confirm the diagnosis of sarcopenia. And along with the above two, if there was low physical performance, then that would define as a severe sarcopenia. Here are a few tests which are advised by European Working Group to assess the above parameters, where skeletal muscle strength can be assessed using handheld dynamometer and 30-second chair stand test. Skeletal muscle quality and quantity can be analyzed using MRI or CT scan, bioelectric impedance analysis, and DEXA scan. Physical performance can be assessed using gait speed, short physical performance battery, and timed up and go test. The objective of our study was to prospectively evaluate for any correlation between sarcopenia and surgical outcome in patients who are being operated for lumbar spine pathology, for which we chose a prospective study design consisting of 114 patients who were categorized into 5 groups based on their age, and they were followed up for a duration of at least 3 months from the date of surgery. The outcome was measured using grip strength, which was analyzed using a standard handheld dynamometer, and the values were compared with the cutoff values of standard Indian population. Similar thing was done with the 30-second chair stand test as well. psoas muscle index was calculated on preoperative MRI at the level of L3 pedicle, and it was normalized to the height of the patient, and the values were compared with the cutoff values of Indian population. ODI scores were calculated preoperatively at 2 weeks and 3 months postoperatively. A difference of at least 12.8% was needed to be called as a clinically important difference. Any perioperative complications were noted and they were graded based on dendoclavin classification. Time to mobilization was classified as early ambulators when the patient was mobilized within 24 hours of surgery, as intermediate when mobilized between 24 to 72 hours, and delayed ambulators when they were mobilized beyond 72 hours of surgery. Length of hospital stay was considered as optimal when it was between 0 to 3 days, delayed when it was between 4 to 7 days, and extended when it was beyond 7 days.
The most widely used being the hamstrings and the bone patella tendon bone graft. The hamstrings, when used, you are sacrificing a pro-ACL muscle. They also have the complication of an unpredictable graft size, and some patients experience thigh wasting post-operatively. Bone patella tendon bone has the disadvantage of anterior knee pain post-harvest, a fixed length, and runs the risk of patella fractures. Bearing in mind these disadvantages, we decided to take up this study to assess the functional outcome of anterior cruciate ligament reconstruction using Peroneus longus tendon, to study the strength of foot eversion and first ray plantar flexion, and to study donor site morbidity. It was a prospective observational study over a period of 2 years, including 40 cases, followed up for a minimum of 1 year post-op. My surgical technique entailed a 2 to 3 centimeter skin incision posterior to the lateral malleolus. The peroneal sheath was incised. As you can see in the image over here, the peroneus longus and brevis tendon were identified. The peroneus longus tendon was then tenodesed to the peroneus brevis tendon, and then the peroneus longus tendon was harvested proximal to this tenodesis site. Arthroscopic ACL reconstruction was carried out according to standard technique. Each patient was evaluated for functional outcome using the Lishom knee score. Thigh wasting was assessed by measuring the thigh circumference and comparing with the unoperated leg. Donor site mobility was assessed using ankle hindfoot score. Foot eversion and first ray plantar flexion strength were assessed by the MRC grading of power and by the use of therabands, and complications, if any, were noted. The results of my studies were as follows. The mean age was 29.7 years, with majority of the patients being male and only one patient being female. Most of my patient population was active individuals, some non-professional athletes playing kabaddi and cricket, 2 were army personnel and 1 was a police constable. The mechanism of injury in 52% of the cases was RTAs and 20% sports injuries. 25 patients had associated meniscal injuries, which were treated with partial meniscectomy and meniscal balancing. We could conclude a statistically significant improvement in the Lishom knee score with a pre-op score averaging at 60.2 and a 1-year follow-up score at 96.7. Only 2 patients had a 1+ laxity, but they were asymptomatic. This could be because of soft tissue graft use. 4 patients had a less than 1 centimeter thigh wasting and 1 patient had a 2 centimeter thigh wasting. The other patients didn't have any significant thigh wasting. We could conclude no statistically significant difference in the ankle hindfoot score. Eversion strength was slightly decreased in 3 patients with a 4+ power and 1 with a 4/5 power. First ray plantar flexion strength was decreased in 1 patient with a 4+/5 power and 1 with a 4/5 power. 2 patients experienced complications in the form of a superficial tibial tunnel infection, which responded well to oral antibiotics, and 1 patient had knee stiffness who was treated with rigorous physiotherapy. So you'll ask me, why did we choose the peroneus longus tendon? The peroneus longus is superficially located in the lateral leg compartment. This makes it quick, easy, and safe to expose and harvest. The peroneus longus and the peroneus brevis have a synergistic action. Otis et al. In 2004 concluded in their study that the peroneus brevis was in fact the more effective everter when compared with the peroneus longus. By doing tenodesis of the distal peroneal longus stump to the peroneus brevis, we aimed to maintain the tension and hence the length in the remnant tendon and preserve the synergistic function of the peroneus longus and the brevis, thus grossly preserving foot eversion and first ray plantar flexion strength post-harvest. Then why not the hamstrings, you ask? The concern was thigh wasting in a lot of the cases. Secondly, the hamstrings act as pro-ACL muscles, protecting the reconstructed ACL from anterior draw forces. The medial hamstrings act as internal rotators of the tibia. This movement is important in sports persons. There is some concern regarding injury to the infrapatellar branch of the saphenous nerve when harvesting the hamstrings. And the hamstrings produces a non-cosmetic scar anteriorly over the knee. Retome et al. In 2019 conducted a study and they recommended the peroneus longus as a superior graft when compared to the hamstrings with the advantage of a larger graft diameter, less thigh hypertrophy, and excellent ankle function. They also conducted another study to assess the eversion and first ray plantar flexion strength when using the peroneus longus and concluded no muscle strength deterioration during eversion and first ray plantar flexion and no donor site morbidity at the harvest site. He et al. In 2020 conducted a systematic review and meta-analysis comparing the peroneus longus with the hamstrings when used for ACL reconstruction. They found comparable functional outcome and graft survival rates. They found a slight decrease in the ankle hindfoot score. However, the patients were not functionally limited. They recommended the peroneus longus as a suitable autograft harvested outside the knee, which avoids the complication of quadriceps hamstrings imbalance, which occurs when harvesting autografts around the knee. No study is perfect, neither was mine. It had a few limitations, being a single-center study with a small sample size, a short follow-up of 1 year, and the use of subjective scores for assessment of outcome. In conclusion, my study had encouraging results with a good functional outcome, minimal donor site morbidity, less thigh wasting, better cosmesis, and an added advantage of preserving the hamstrings, which act as pro-ACL muscles. I would recommend the Peroneus longus as a promising primary autograft. We aim to continue this study and follow up the patients for a longer period of time and hope that in the future we are able to do a multicentric study. Thank you.
Thank you, Dr. Sasha. Questions?
Hello. So my question to the speaker who just spoke about the Peroneus longus.
Yes, sir.
What kind of ankle stability score testing was done, especially in the runners? Because I feel Peroneus longus is the most important muscle when you think about using it for a primary ACL reconstruction instead of doing it in multi-ligament reconstruction. Correct. So what exactly was tested when you did it in the sprinters, runners, long runners, and army personals?
Sir, we were very lucky that we did not have any patient who presented with us with an ankle instability already. We had decided to screen patients and not include them in our study if they had an ankle instability prior to harvesting the graft.
Okay, thank you. Next question, please.
Yeah. I'm Dr. Sanjay from my NHS Ashwini. My question is, when you do the tenodesis here, when you do the tenodesis, what is the position of the foot? Like it's in slight inversion, neutral, or full eversion when you do the tenodesis of remnant to the Peroneus brevis?
Sir, either neutral or in slight inversion, sir.
Okay.
Yes, sir.
Dr. Jayesh Shah.
Excuse me. Number one, this side.
Yes, sir.
What was the size in terms of the length and the diameter of the donor before and after preparation for the graft?
So we were able to get between 9 and 11 by doubling most of the times we doubled the harvested graft, and we were able to get a diameter between 9 and 11.
So
Yes,
if
sir.
after taking Peroneus tendon, longus tendon,
Yes, sir.
there is no disability, even in runner, military person,
Yes, sir.
I want to know if there is traumatic transaction, there is no need of suturing it.
Sorry, sir. Please, could you repeat your question?
So if there is no disability after taking graft of Peroneus longus tendon,
Yes, sir.
and there is no disability in runner and military person, as you have tested,
Right.
if there is transection, traumatic cut of Peroneus tendon, there is no need of doing suturing.
Sir, we actually we wanted to preserve the eversion strength, and Peroneus brevis was more active as an everter, but Peroneus longus does have some effect in eversion. So we didn't want any decrease in the strength, is why we went for tenodesis, sir.
Yeah, thank you, Sasha.
Thank you, sir.
I would request again, instead of comments, just ask a brief question so that more people can ask. Thank you. So we call upon the next speaker. Yeah.
Call upon Dr. Darshan Mahesh Kapoor for his paper. Regeneration of Tendo Achilles following complete tenotomy in club feet treated by Ponseti's method in children older than 1 year, a clinical and sonographic case series. Dr. Darshan.
Good morning. Hello. Yeah. Good morning, respected chairperson, respected judges, seniors, and dear colleagues. I thank Wiroc for this opportunity and acknowledge my co-authors for this opportunity to present our research, which is the regeneration of Tendo Achilles following complete tenotomy in the walking age clubfoot children. This study was conducted at Wadia Children's Hospital in Mumbai. The Ponseti method is a standard of care for the treatment of clubfoot since early 2000s. Recent evidence suggests that it can be successfully used with high success rates even in the older children, as supported by our own article. The tenotomy of the Tendo Achilles is an integral part of the Ponseti method. However, due to limited evidence, there are no clear guidelines regarding the techniques required when the tenotomy is performed in the older age group. There is no doubt about the healing of the Tendo Achilles when it is performed in the infant age group. But does the Tendo Achilles regenerate completely when it is performed in the older child? To answer this question, we conducted this study to understand the regeneration of Achilles tendon using sonography and clinical outcomes in children in whom tenotomy was performed above the age of 1 year. The Ponseti method was adopted as a standard of care since 2003, and a dedicated clubfoot clinic was started in our hospital since 2011. The prospectively collected data was gathered on a standardized approved proforma through the International Clubfoot Registry. This study is a retrospective analysis of the idiopathic clubfoot children above the age of 1 year who underwent tenotomy as a part of the Ponseti method from 2011 to 2020. Serial weekly casts were applied in the outpatient department, followed by a percutaneous complete tenotomy performed by a 15-number surgical blade under general anesthesia in the operation theatre. A complete tenotomy was confirmed with a sudden pop, increased dorsiflexion, and a palpable gap clinically. If adequate dorsiflexion was not achieved, serial weekly casts were applied later till 15 degrees of it was obtained. The treatment was provided by pediatric orthopedic fellows. A sample of 20 children, 31 clubfeet, who met the following inclusion-exclusion criteria were contacted telephonically and evaluated at their last follow-up, minimum of 6 months. They were evaluated using the clinical, functional, and the ultrasonographic parameters on a single sitting. The clinical assessment included the ankle active range of motion with the child placed in supine position and the knee extended using a handheld goniometer. The Tendo Achilles power was measured using MRC grades. The functional evaluation and the endurance testing of the Tendo Achilles was carried out by a validated heel raise test. In this, the child was asked to stand against a wall and the heel raise was asked to perform every 2 seconds with a target of 30 heel raises per minute. The test is terminated and the number of heel raises per minute is noted if the child stops performing or is not able to maintain the frequency or is not able to do it properly. The highest height achieved during the entire test duration is the height of the heel raise, which was measured using a smartphone camera placed on the floor level. The sonographic parameters was used because it non-invasively demonstrates anatomical continuity. A single senior sonologist performed all the scanning with more than 15 years of experience in the pediatric musculoskeletal scanning. It was done using a hockey stick probe with the patient in prone position at the level of scar mark, and it was done in the axial and longitudinal planes. The entire Achilles tendon was scanned from proximal musculotendinous junction all the way distally up to the insertion, and any thickening, fibrosis or scarring was noted. The quantitative parameters include the tendon width and thickness measured in centimeters, and the qualitative parameters were a dynamic continuity and a ecotexture of the tendon. Moving on to the results, of the 31 feet in our study, 11 cases were bilateral and 9 were unilateral, where the opposite side served as control. The mean age of tenotomy performed was at 2.6 years. The mean age at final assessment was 7.7 years, with the youngest child assessed at 4 years of age and the oldest at 11 years of age. The mean age at the follow-up period was 5.2 years. All Tendo Achilles power measured was MRC grade 5. The number of heel raises per minute was 24 per minute, and the height was 6 centimeters. The ankle dorsiflexion measured was slightly lower at a mean of 16 degrees with a range of 10 to 25. The ankle plantar flexion was a mean of 43 degrees. All tendons showed intact dynamic continuity on scanning, and the hallmark of healing was a homogeneous ecotexture, which was noted in all cases except for one patient who had heterogeneous ecotexture on the scanning, but an intact clinical and functional outcome. There was no significant difference in the tendon dimensions on comparing on both the sides in bilateral cases. However, on comparing the tendon dimensions in unilateral cases, where the opposite side foot served as control, there was slight reduction in the tendon width. This is a case example of a 11-year-old girl with bilateral clubfoot, where the tenotomy was performed at 3 years of age. At 7 years follow-up, she had good recovery of the clinical and functional outcome and a homogeneous echo texture and a comparable tendon dimensions on the scanning. On reviewing the literature, there have been few studies looking at the regeneration of Tendo Achilles after tenotomy with a supporting clinical and or imaging parameters in the form of sonography or an MRI scan. However, in all these cases, the tenotomy was performed in less than 1 year of age. There was one study by Matthew et al., which was studied in older age group children, but they evaluated only clinical parameters. In contrast to all these studies, our study is unique, where a clinical as well as sonographic parameters was combined used, and the tenotomy was performed above the age of 1 year. As per our knowledge, ours is the first study to conclusively prove that Tendo Achilles regenerates completely after a percutaneous tenotomy in the walking age clubfoot child. At mean follow-up of 5 years, adequate dorsiflexion was achieved and a normal Tendo Achilles power was measured without any functional restriction. Intact dynamic continuity of the Tendo Achilles was confirmed on sonography and with a homogeneous echo texture and almost normal tendon thickness and width as compared to the opposite side. Limitation of our study was it was a sample which was smaller at a single center and the subjectivity of the sonography as a method of evaluation. Did we find answers to the question with which we began our study? Ladies and gentlemen, we firmly conclude that the Tendo Achilles, the strongest tendon in the body, unites completely after a tenotomy in clubfoot cases above the age of 1 year, as proven by the clinical, functional, and sonographic parameters. I thank you all for the attention listening.
Yes, Dr. Milind.
Darshan, that was a great paper.
Thank you, sir.
Based on this study, till what age you would recommend a complete TA tenotomy? That's the first question. And the second one, you please go ahead.
Thank you, sir. That's a nice question. So in our study, the highest tenotomy which was performed was at 6.5 years. We have a similar paper of the treatment done in the walking age group, where the highest age recommended was up to 10 years.
The next question is what you do if after tenotomy your correction is not full? You keep on doing casting or?
Yes, that's what was just showed there. So the serial weekly casting were adequated, that was performed in the outpatient department weekly till 15 degrees of it was achieved.
Thank you, Milind. Yeah, next question you can ask, sir.
Yes, hello.
Kindly introduce yourself.
My name is Roshan. I want to ask this speaker.
Roshan, let's give somebody else a chance. He's here since before you. Yeah.
Yeah, that's a nice paper. I'm Dr. Tausif. Darshan, we have 3 probes in ultrasound: curvilinear probe, linear probe, and the hockey stick probe, what you have shown.
Yes.
So, what is advantage of using a hockey stick probe over all these 2 probes?
So the hockey stick probe is the one which has higher frequency, and it was the one which has a better resolution of the superficial imaging. And it is much smaller and easier to hold. So when we do the scanning in the children, it is much better with respect to the resolution, and more dependent is the more subjectivity and the thickening and the measurements of the sonography is better performed.
My question to the speaker is about the type of tenotomy. Do you do a complete tenotomy with the tendon sheath, or you do intratendinous tenotomy? Because that is going to decide the outcome of your tenotomy healing, especially in children and then later on the older age group. So do you do a complete transaction of the tendon along with the tendon sheath, or you do a intratendinous tenotomy?
Sir, in all cases, the tenotomy was performed by percutaneous method, and only till the complete tenotomy was performed, which is confirmed by the 3 points, that is the palpable pop, increased dorsiflexion, and a palpable gap clinically. So that is the confirmation that the entire tenotomy, it was complete.
Thank you, Darshan. Please come and collect your certificate. So we call the next speaker Pallav Praful Agarwal. He is going to speak on analysis of proximal femoral lengthening for post-traumatic reconstruction.
Respected chairpersons, teachers and friends, I'll be speaking on analysis of proximal femoral lengthening in post-trauma reconstruction. Difficult femur non-unions can present with infection, deformities, bone gaps and shortenings. There is a lot of literature, experience and progress with modern methods to achieve union at the non-union site. But there is very little literature that addresses the problem of shortening associated with distal femur non-unions. So the true shortening is the bone gap plus the external shortening revealed by full length or full segment x-rays. So a question arises, is proximal lengthening possible safely and simultaneously with the treatment of difficult or infected middle third and lower third non-unions? And how does the proximal regenerate behave while lengthening? We studied 115 proximal femoral lengthening in such cases. We studied these 4 parameters and focused on angulation at the regenerate bone. We tried to find the correlation of angulation with general pin-related, osteotomy-related and non-union-related parameters. In our study, 16 were female. The mean age was 36 years, ranging from 10 to 65 years. This was the laterality. Most were in the lower third of the femur. The mean preoperative shortening was 84 millimeters, ranging from 24 to 270 millimeters. Half of them were infected. Either 3 or 4 pins were used depending on the type of external fixator applied. A hash configuration with 2 pins going up the neck and 2 coming down the trochanter were used in 68 patients with Elizarov, and a parallel configuration in 47 with LRS. An oblique osteotomy to increase the regenerate area and possibly prevent varus angulation was done in 23. 56 were comminuted, 26 were oblique, and 28 unions had a transverse bony ends. The distance of osteotomy was measured from the base of the lesser trochanter and classified into 2 groups of less than and more than 30 millimeters. A standard operative technique was used to fix the femur with an Elizarov or an LRS in all our cases. A percutaneous osteotomy was done using drill holes and 6 to 10 millimeters of osteotomes in all our patients. So this ensured minimum damage to the periosteum and no gap or translation at the osteotomy site. So when 3 out of the 4 cortices in AP and lateral and 5 out of the 8 cortices in AP, lateral and oblique x-rays were mature, we took it at the lengthening duration, though the fixator came out only once the non-union healed. This paper does not focus on non-union management, and we measured the angular deformity only in coronal plane, as it was difficult to take true lateral x-rays in proximal femur region in many patients. So a case of LRS-assisted lengthening was done in a case of infected non-union after thorough debridement and antibiotic cement block. A length of 92 millimeters was achieved at the lengthening site. Infection was eradicated, non-union was achieved with minimum residual shortening and angulation, and this leading to a mild mechanical axis deviation. We achieved a mean lengthening of 64 millimeters, ranging from 14 to 180 millimeters. Equal limb lengths were seen in 14% of our patients, with a mean residual shortening of 23 millimeters in the rest. The lengthening index is a subjective measurement of time taken for complete consolidation of the regenerate, sufficient for the fixator to be removed theoretically. External fixator index is the overall duration till the external fixator removal and is influenced by the excess time taken up by the non-union to heal. Hence, this reflects the relative ease and speed of the lengthening of new regenerate bone proximally and the difficulty of the non-union healing. Another method was regenerate maturity was also determined by measuring the width and pixel value ratio to decide the hardening of the regenerate using ImageJ software. Complications. So, this neurologist had 5 failed previous surgeries with persistent infection and oblique non-union with mild shortening. The regenerate went into a premature consolidation at 24 millimeters and he refused a repeat osteotomy. TSF helped achieved horizontal compression at the non-union site. He healed well with very little delta MAD. The small shortening reflects some loss of length by compression at the non-union site. Around 20% of our patients had premature consolidation, some needing repeated corticotomy, which shows that there was exuberant bone formation. Repeated osteotomy was done multiple times, maybe once, twice, or even thrice. Causes. As there is simultaneous turnings at multiple connections at the 2 sites at different rates, some patients were confused and did improper turning. Non-parallelism of the distraction mechanism was one of the other causes. Inadequate medial distraction also leads to premature consolidation. We equalized the distraction by converting the 120-degree arc to a 360-degree uniform distraction and adding an empty ring to the construct. Over-distraction, which can cause a poor regenerate, as in this case infected non-union with a 10 centimeter shortening, the patient wrongly over-distracted 70 millimeters in 30 days. As a result, bone formation was deficient. We did accordion maneuver with bone marrow injection at the lending site. It took around 7 months for the regenerate to unite. So the commonest complication was a varus deformity. 66 had excellent results. Only 25 had a deformity greater than 15 degrees. Only age and weight correlated moderately with the angular deformities. All other parameters like distance from, number of proximal pins, shape of the non-union, pins configurations, distance from the lesser trochanter, total lengthening achieved, and osteostomy shape had weak correlation. One of the causes of varus angulation at the regenerate was a distal deformity. A case with a varus non-union at the femur with a valgus malunion at the tibia, we did proximal femur lengthening and saw that the regenerate was going into varus. We observed that any deformity distally will automatically angulate the soft regenerate. So in this case, the regenerate automatically corrected as the distal deformity was gradually aligned. Pin loosening was seen in 24 of our patients and had to be revised as a minor procedure. The pressure of the bed in the posterior part of the arc tend to cause the proximal pin loosening. Hence, we use a cut mattress in all our indoor patients and ask them to use it at home also. Out of the 115, 109 united, we used augmentation with bone marrow injection in 39, autologous bone grafts in some because most patients had exhausted bone graft sites and some refused. I would like to wind up with an interesting case. A young IIT engineer with a huge femoral bone loss who wanted equal limb lengths and knee range of movement, treated innovatively by a primary orthopedic surgeon with a custom prosthesis to maintain the length. We started lengthening with extra long LRS rail and a distal Elizarov. The task given to us was to give him a complete length for a future total knee replacement. We gave him the biggest length of our study with a residual limb length of 22 millimeters. He is now awaiting for an arthroplasty surgeon to take up his case. Perhaps ours is the largest series of proximal femoral lengthening in post-traumatic reconstruction. I would like to conclude that look for and simultaneously treat shortening in distal non-unions. Premature consolidation is common due to good bone formation. Look for and treat varus deformity in older, heavy patients. Persistent varus may not dramatically alter the mechanical axis compared to the opposite side. Greater efforts are needed to speed up healing at the difficult non-unions. Thank you.
Any questions? Yes. Yes, Swapnil.
Good morning. I want to know what is the indication of oblique proximal femoral osteotomy in your study and what are the advantages and disadvantages of that?
Sir, the only disadvantage of oblique osteotomy was, sir, it was more difficult to do due to the placement in the lateral view. It was not very clear. The straight osteotomy took a lesser time. The transverse osteotomy took a lesser time.
I want to ask you one question here. Hello.
Dr. Karkanis.
Okay, doesn't matter. What is the range of movements of the knee that you got because of so many pins going through the quadriceps and the patient having a non-union to start with?
Sir, thank you for the question, sir. Around 80% of our patients came with already a very stiff knee due to multiple surgeries, prolonged immobilization, and more than 80% of our patients had a knee range of movement of less than 30 and around 40% had no range of movements. And we did a few quadriceps plasty, but the knee range of movement was still restricted in all our patients.
I have a question. So, how many did you use Elizarov and how many did you use LRS?
Sir, 68. 68 were Elizarov, sir.
And have you shifted more of them to LRS in recent times?
Sir, actually, we had to shift a few patients of LRS to Elizarov because it went into varus angulation.
And what was the average number of surgeries one patient had to undergo?
Sir, pre-operatively, sir, the average number of surgeries was around 6, and post-operatively, sir, only in 15 patients we had to convert the LRS to an Elizarov.
Okay, thank you.
Thank you.
Please collect your certificate. So So we invite the next speaker, comparison of lengthening over nails versus lengthening with external fixators, again from the same institute, Ishani Milind Chaudhary. Yes, Ishani, go ahead.
Chairman sirs, esteemed audience and friends, I'll be comparing lengthening over nails, LON, and lengthening with external fixation. Limb lengthening is needed in congenital, developmental, and post-traumatic, infective, and neoplastic sequelae. The LRS, Ilizaro, and hexapod fixators are routinely used for limb lengthening. Lengthening over a nail was described by Paley in 1997, after which it has been routinely used. But there's not much literature that compares these two techniques. We aim to compare LON with fixators. Our study consisted of 111 segments of LON compared to 115 segments with external fixation. The mean age of LON group was older at about 26 and of LEF was around adolescence. We use the Ilizaro fixator in 28 femora and 65 tibia, the LRS for only femurs, and TSF saw the least use. 61 tibia had the standard tibia trauma nail, special straight nails were used in 39 femora, and humerus nails in 4 femurs and 8 tibia as described by Gordon. LEF was done by the standard method. LON required special but affordable instruments like the straight nail, the rigid reamer, polar screws, and accurate planning, which was done with the help of full-length X-rays, full segment X-rays in AP and lateral, and the magnification markers, which helped to choose the nail with a proper length and diameter. The access viability of the entry point was important. The LON procedure, external fixator pins inserted, reaming done, nail inserted up to the planned osteotomy site, osteotomy done, nail inserted further and locked only proximally, kept free distally to let sliding and lengthening, external fixator removed and nail locked distally after length is achieved. Note that the external fixation pins were posterior to the nail. Now, LON was indicated in non-infected cases, in roomy patent canals, accessible entry points, and usually after skeletal maturity. Illustrating some cases, now in this case, LON could not be done in the femur because the canal was narrow and sclerotic, and hence LEF was chosen. In this case, proximal entry for the LON was not possible due to severe coxa valga, and distal entry was not possible due to patella baja, so the LEF was done. LON was mostly done after skeletal maturity. In 4 pre-adolescent patients, we have used the humerus nail through a trochanteric entry as described by Gordon. We analyzed the outcomes based on the length gain, percentage lengthening, external fixation duration in days, and index as days per centimeter. We calculated the level of difficulty score as given by Paley and noted the complications. This was a retrospective level 3B study, and the 2 groups were matched for the level of difficulty score. We found that mean length gain was similar in both methods. Percentage lengthening was significantly more in the LEF group. For the same amount of lengthening, external fixation duration and index was half in LON, and this was statistically significant. The level of difficulty score was similar, and the groups were comparable. Comparing the nuances of LON and LEF through cases, this 2-year-old child post-septic bone gap of 4 centimeters and external shortening of 6 centimeters had a fibular graft to fill the distal defect, and proximal corticotomy with the Ilizaro was done. The defect filled well, the length was achieved within 6 months. This highlights the utility of the Ilizaro fixator in complex cases like bone gaps, where no other fixators, especially at his young age, would have worked. For the 16-year-old girl with 3 centimeters shortening and valgus in the femur, the valgus was corrected acutely using Rule 2 of deformity correction, and lengthening was done gradually. The LON enabled early fixator removal in just 1.5 months. But in contrast, for the similar shortening and deformity, LEF took much longer to gradually correct and lengthen through the same site. In this femoral overriding malunion with 4.5 centimeter shortening leading to LON, he achieved target length in just 2.5 months with full knee flexion in 3 months post-fixator removal. In a case with similar discrepancy where LON could not be done, he got LEF, but it took double the time, and post the fixator removal, his knee range of motion was only 70 degrees. A case of double femoral and single tibial LEF done in the same patient with a large discrepancy. The severe tibial deformity as a sequela of compartment syndrome. 5 centimeter length was achieved very fast with the LON in the undeformed femur, and he was free from the fixator soon, but the tibial lengthening happened gradually along with the deformity correction. A case of double femoral and single tibial LEF done in the same patient with Olier's disease, dysplastic bone, large shortening, as well as large multiple deformities. The LEF was the only option in such cases. Over 15 months, he gained the lengthening and deformity correction amounting to 19 centimeters, and repeat lengthening was done again with LEF after 2 years. We noted the complications: deep IM infections, premature consolidation, axial deviation. While superficial pin tract infections are commonly known, deep IM infections were noted in LON, but LON prevented severe axial deviations. The other complications of LON, like nail break and loss of fixation, were treated by converting to LEF. The solution for the deep IM infection is remove the nail, ream, debride, maintain or add external fixation, insert an ABC rod, add antibiotics as per culture. All the infections were resolved. One had a sequela of knee stiffness. When premature consolidation occurred, we solved it by extracting the nail partially, repeat the corticotomy, reinsert the nail, and lock the nail distally. And the lengthenings continued. In one case, we needed to convert the LON to LEF, and in some cases, the patients refused a repeat corticotomy and the length fell short. The obstacle of knee stiffness, as in this patient, was solved by quadriceps plasty and arthrolysis. This was usually done 6 months to 1 year after the fixator removal. Coming to the discussion, literature review showed that the other studies mostly had single segments and far lesser numbers. Only in one study by Sun et al., it was more segments, but they were all cosmetic lengthenings and only in the tibia, so their level of difficulty was less. The strength of our study was the large numbers, the comparison, both used in the tibia as well as the femur, and the high complexity of the cases. The limitation that the group was not matched by age and etiology. Analyzing our large series, we found that LEF is versatile, can be used in all ages, causes, segments, deformities, and can correct complications of LON. But LON is convenient for the patient as compared to LEF and extremely cost-effective, almost 50 times so as compared to advanced internal lengthening nails. LON efficiently corrects wide range of shortening and deformities, as in this case of a radiologist with fibrous dysplasia who had shortening of 12.5 centimeters. Double level deformity correction was done with the LON, and he achieved target length as well. In conclusion, both LON and LEF are effective for lengthening and deformity correction, but lengthening over nails significantly reduces the external fixation time, helps with faster knee range of motion recovery, and is very convenient for the patient. But LEF has universal applications and can solve most complications of LON. Paying homage to Dr. K.S. Masalawala's memory, I thank you for this opportunity.
Thank you, Ishani. Any questions? Yes, Dr. Mukhi.
Who is the real originator, Heisenberg or Paley?
Thank you for the question, sir. Regarding the level of difficulty, it was mentioned by both the authors. Originator of the technique.
Yeah.
We've referenced it from Dr. Paley's paper, so would go with that.
It's the Heisenberg who was doing it first.
Thank you, sir.
So if today you have to do this procedure, which will you prefer?
Sir, I would prefer lengthening over nails, provided that after proper analysis, the indication for the LON is there with the analysis of the deformity.
Okay.
Thank you for the question, sir.
There is one more question, Dr. Rajveer Chennai.
Just a small comment. Compliments to Milind on 2 papers from 1 institution.
Thank you, sir.
Yes, Ishani, please come and collect your certificate.
Thank you.
We call upon the last speaker of the Masalawala session, Dr. Ashish Pathak. He is going to talk on alignment and total knee replacement when distal femoral cut is taken as planned on long leg standing radiographs, a study of 115 patients. Please start the timer.
Can I start?
Yes, you can start.
Alignment in the total knee orthoplasty when the distal femur cut is taken as planned on the long leg standing radiograph, a study of 115 patients. Mechanical alignment was first described by John Insall, which leads to the equal loading on the medial and the lateral surface. Acceptable alignment is 180 degree plus or minus 3 degree due to the constitutional varus present in the general population. Outliers more than 3 degree varus or valgus will lead to implant failures and implant loosening. So in conventional TKR, the tibial mechanical tibial mechanical anatomical axis are the same. Hence the extramedullary jig gives the predictable outcome. While in the femur, distal valgus cut is taken with the help of intramedullary jig with a valgus correction angle. This angle, as in the femur, because this difference between the femoral mechanical and anatomical axis, ideally this valgus correction angle should equal to this difference between this femur's anatomical and mechanical axis or the fama. The fama is not a constant, it is a very wide variations are observed, and factors affecting to the fama or the coxa. Factors affecting are the coxa vara, valga, femoral bowing, and severe deformity. In our study, we have done the preoperatively measurement of the fama on the long leg standing hip to ankle radiograph of both lower limb. Intraoperatively, distal femur cut was taken variable depending on the preoperative fama. Radiological assessment was done in the after 3 months with a scanogram, and functional recovery up to 12 years with OKs and KSS. So we have included only primary TKR with the patient of arthritis with varus deformity, the patient having fixed flexion deformity more than 15 degree and January curvatum were excluded from the study. A constant technique of taking the scanogram is very important, where the fixed distance is followed and the neutral alignment, neutral rotation of the limb is important. It has been confirmed when the maximum knee extended, both feet are parallel and patella is facing forward. And the scanogram has to be well weighted on the, for the correct alignment, with the half of the lesser trochanter is seen on the medial half of the fibular head should overlap with the tibial metaphysis. In the knee, the rotation is correct, then it will form patella is the center with a dome shape. Well, if it is rotation is not correct, then the patella is eccentric with a triangular shape. So once the scanogram is obtained, we do some measurement. First, we do the center of the femur head by marking the circle, appropriate circle with the packs. Distal femur midpoint is marked with this medial edge of the femoral notch, from where the femoral jig entry is to be taken, and then we measure the lower limb alignment, this femoral anatomical and mechanical axis difference. All surgeries were performed by single surgeon with a medial parapatellar approach. In surgical technique, the tibia extramedullary chip is used with the 3-step technique, applying it to the fixed anatomical landmark, proximally and distally, check the jig parallel to the jig, and correct the check the alignment after the tibial cut also. The femoral entry is important, and it is taken 1 centimeter above and 2 millimeters medial on the right sideline. Important is to over drill the femoral entry In our case, we have taken 8 millimeter rods with the 12 millimeters of over drilling. Follow-up after 12 months, 3 months, we have done the scanogram, and we have observed that in 115 patients, in 155 knees, 29 male and 86 female with average age 67 and 68 respectively. We have found that pharma is varied from 5, there is variability of the pharma with the minimum 4.2 to maximum 6.7% with an average of 6, where the majority was found between 5 to 6%, 6 to 7 degrees of pharma we have found in 35% of patient. Below 5 degrees we have found in 13% patient, and above 7 there was in almost 16% patient. While comparing the distribution with the neck shaft angle and the femoral bowing with the pharma variation, the neck shaft angle has a significant correlation more than the femoral bowing. Coming to the intra-op distribution of this valgus correction angle, we have taken maximum number of percentage was at the 5 degree. Next, we use the 6 degree. But above 7 degree was required in almost 26% of the cases, and less than 5 is used in almost 3% of the cases. Coming to the pre-op and post-op limb alignment. Coming to the post-op and pre-op limb alignment, preoperatively average varus was 19 degree, where the maximum cases was below 15 degree. Post-operatively, the average varus varus noted was almost 1.9 degree, and more than 3 degree was observed in 3 cases. Functional outcome, the preoperatively this Oxford knee score and has the knee society score, the difference is statistically significant. There is a wide distribution of this femoral anatomical and mechanical axis in arthritic population ranging from 2 to 9%. Various factors are there. Neck shaft angle effect. In our study, the variability was from 4 to 8 degree, and 29% values were less than 5 and above 7 degrees. Fixed 6 degree valgus cut has shown acceptable result up to 86%. Also, the meta-analysis of the individualized VCA shows the predictable improved outcome with the variable VCA. So in our study, we have achieved the acceptable alignment in 97% of the cases. The 3% malalignment we have found, or the outliers were due to the varus malalignment. Short-term functional outcome shows good result, and our study is a short-term study with a small numbers. So we recommended that all primary TKR should be evaluated with the long-length standing X-rays preoperatively to find out pharma, and take a variable cut intraoperatively depending on the pre-op pharma.
Question?
Yes. Did your study have any difference in the patient-reported outcomes? Did it make any difference in the patient-reported outcomes?
Functional outcomes, sir?
Yes.
Yes.
Patient-reported outcomes, not functional outcomes. So patient is happy, unhappy, depending
No,
on
sir,
what?
we haven't studied that patient-reported outcome.
Okay. Okay, if there are no more questions, kindly come and collect your certificate, please. So with this, we conclude our session.